esophagus.
Oh,
And then over here, looking in lips, teeth, tongue, hangy downy part, that's the uvula. There's our tonsils off to the side. We have the connector. Has anybody ever had their tongue clipped, or any of your kids ever had that done? If you raise your tongue, underneath you have the little thing that connects it. That's the philtrum. And then you have the one up on top, the frenulum. Philtrum up here connects our top lip to our teeth. And down here, philtrum up here, frenulum down here. So this is the philtrum. And then down here, connecting the tongue to the floor is the frenulum. So sometimes that is too short, and the child can't speak properly, or they'll say they're tongue-tied. And you need your tongue to form words, so you need to be able to put your tongue on the roof of your mouth and move your tongue around. That's how we learn how we make sounds. And sometimes that's too short, so they'll have to get that clipped, and then they can talk properly. And that's what speech therapy is all about, is for whatever reason, we're not using our tongue properly. So children will start to go to speech therapy, depending on how bad it is. Kindergarten, first, second grade, sometimes they're like, oh, they'll grow out of it, they'll figure it out. And if they don't, then you go to speech therapy, and you learn how to move your tongue properly, how to place your tongue. So R's and T's, common things that people have trouble with. And they look at a mirror and they'll say, put your tongue on the top of your teeth, because they're not forming their R's properly. And they'll practice with like rooster, red rooster, the red rooster roars. So you practice with that, or your L's. You give them little rhymes. And they usually end up liking it, because A, you get out of class, so yay, that's fun. B, you get to go down to a special class. Sometimes you don't like that, because that makes you feel different. But you go down there and you find out you get candy when you go to speech therapy, so you want to stay in speech therapy. And then you get to play little games, and then you go back to class. So when my youngest, he had troubles with his L's, and I won't tell that story. But he had troubles with his L's, and so I made up, and he's always has been very strong-willed, and his name was Willie, so it was a problem. He was Willie. And so I made up a rhyme. Lola likes lovely lemon lollipops. And I gave him that rhyme, and I would hear him in his room practicing, and it took him about a week, and then he was fine. And I said, watch in the mirror what you're supposed to look like. And he got it down in about a week, and he was good. But he didn't want to be different. He didn't like, plus it was part of his name, so it was hard to say. And so we got him through that. And then, in kindergarten, they evaluate you, and they'll put you in speech therapy and all that. So he's like, I'm not going to that class. Then he found out you get out of class and you get candy, and you get to get out of reading class or whatever it is you didn't like. So he's like, oh, maybe I'll go to speech therapy for a little bit of time. He kind of liked speech therapy. And he was just like on the edge of coming out of it then. But so the tongue is a very important part of speaking, and sometimes there's anatomical limitations, and they'll have to clip that.
So they just stick your tongue out, right?
And you can't stick your tongue out, right?
Or you can't curl it back.
Right, either. So it's too tight there, and they put in and clip that part. All right, so that's the mouth. We know we have the hard palate and soft palate. And then the tongue occupies the floor of the mouth. The tongue does lots of things. It's kind of like our fingers and our toes. It's grippy. It has the papilla, or our taste buds, on there. So the tongue helps grip and reposition food during chewing. Think about how you are when you've had your tooth, you've had a cavity, and you're numb, and you can't talk right, and you can't eat or you can't chew because you can't feel your tongue. So you really don't think about your tongue until your tongue doesn't work, or until you burn it, or the roof of your mouth. You're like, oh, this is horrible. So it grips and repositions food, helps mix it in with the saliva, and it's the thing that pushes back for swallowing. So that's the last part of voluntary. It helps with speech, what we talked about, and obviously taste. So we have taste buds. And this is what happens with like ALS, Lou Gehrig's disease, is it destroys muscle function. So they start having a hard time with eating because they can't chew things. The tongue's a big part of that. And they lose the message, the neuromuscular junction gets interrupted in Lou Gehrig's or ALS, and they start having a hard time chewing, and they have a hard time swallowing. So that's usually towards the end, and then they go on to a feeding tube or something. But they can't feed themselves because they don't have muscle control of their arms or their hands. They start losing fine motor. They can't hold a spoon or a fork, or they can't hold a glass. Things that we totally take for granted, you don't even realize these are part of your daily activities until you can't do it. But that's a big part of it, is once you start losing the swallowing function. And that's all related to oral
And is this
stuff.
formation of, what did you say about that?
The bolus. That's the food stuff. So once we chew it up, it's no longer food, we call it a bolus. That's what we start swallowing. And there's our tongue. We have lots and lots of taste buds on it. We call them the papilla. You don't have to know all the details of that. And then we have our tonsils back here on the back of it. That looks like the normal tongue. Tongue tells us a lot about our health, what's going on. Scalloping tongue, if you look in the mirror and it's kind of wavy looking, that's often an indication of a thyroid condition. So let's look at your tongue later, see if you have ridges in there, scalloping. Is your tongue coated? What's going on with that? It shouldn't be all white and yucky looking. It should be mostly pink. So that tells us different things about, there's whole books out there on the tongue and what it means about your health. So Google it later and see. There's all kinds of theories of what's going on there. Teeth, do we have any dental people?
I'm not in the field,
Teeth, we're not going to get too deep into that. Deciduous teeth, a deciduous tree loses its leaves in the fall. So we call our baby teeth our deciduous teeth because they fall out, just like the leaves fall off the tree. Total of 20 that come out, and they'll be replaced then with 32 permanent teeth. Maybe have more, maybe have less. Everybody has a variation in there. And so we have all our different types of teeth. We're not going to get into that. Just know that baby teeth are deciduous teeth, and then hopefully we replace those with 32-ish permanent teeth. Very important for digestive health. The 3 salivary glands, the parotid is our ear and kind of in our cheek. Underneath our tongue, sublingual, below the tongue. Underneath our mandible, submandibular. Those are our salivary glands. And they secrete salivase, the enzyme that helps break down food. This is also the one that's affected by mumps, the parotid gland. So when we get the MMR vaccine, that's one of the things, one of the reasons we get that is the MMR, measles, mumps, rubella. The mumps can affect the parotid gland. That's why you get chipmunk cheeks. We know about that part. But in males, it also likes to go to the testes. So that's why men are a little more vulnerable. If they get the mumps, you're a little more concerned with the little boy getting it than a female. Obviously, we don't have testes. But with a male, it likes that particular tissue. So it can cause inflammation, which can lead to sterility. So the mumps part of that affects the salivary glands and the testes as well. That's the MMR, measles, mumps. All right, saliva. So saliva is very important. It keeps our mouth lubricated. And again, we don't think about it until it becomes a problem. You get dry mouth or you're over salivating for whatever reason. So saliva is mostly water. It has enzymes in it to break the stuff down. And it's bacteriostatic, so it's going to help break down some bacteria. It helps protect us. So it cleans, it buffers the pH again. IgAs, that has to do with immunity stuff. And lysosomes, remember lysosomes are the soldiers that go around and defend and protect. Saliva helps us moisten our food. We've all done this before when you do like eat the crackers and try to whistle. You can't do it because there's no moisture in your mouth. So we know saliva is good for moisture in the mouth. Helps with digestion. We have salivary amylase, ASE, so we know it's an enzyme to help break down carbohydrates. Lubricates, just keeping things moist. And then the MMR, what we talked about, the measles, mumps, rubella, helping protect the parotid salivary gland. Can lead to sterility if it gets too inflamed, it gets hot, and then it overheats the sperm, and then the sperm are inactive. So that's the whole long story behind that. More on that in the reproductive. Any questions over saliva? So this is what happens when you go and have some kind of surgery, is they give anesthesia and they decrease your salivation. So when you come up out of whatever you've been under, you're so thirsty, because they don't want you salivating. They want to minimize that. They want your mouth to be nice and dry. So that's why you're so thirsty. If you've ever had your wisdom teeth out and you wake up and we see all these funny videos of people, you know, in twilight, they're saying all kinds of crazy things because they're so thirsty. When my older one had his wisdom teeth out, he's a firefighter paramedic. And people get a little agitated, you know, they're coming up out of that state and they don't know what's going on. So he came up and he's like, I'm so thirsty. And I was like, it's fine. And they keep you there until you come up out of your sedation. And they watch you for 30 minutes, monitoring your heart rate, making sure everything's okay. He's like, I just want something to drink. And I'm like, wait, 30 more minutes, you'll be fine. And you know, when you're thirsty, you're thirsty. And he's still, you know, 50% in, 50% out. And the nurse is in there, and she was great. She's like, and you have to be there because they're not going to remember anything. And she's telling me whatever. You know, eat soft foods and drink. He's like, I'm about ready to get that tube over there and rip it off the wall and intubate myself and start drinking. I'm so thirsty. So she was laughing, I was laughing. He's like, it's not a fight. You gotta do it. And he's like totally non-aggressive, Mr. Calm kind of guy. So it was so funny. And then finally he gets home and I bought him, you know, like applesauce and yogurt and pudding and stuff like that. And I thought, oh, maybe these, you know, like the naked drinks, the fruit drinks. And like maybe that, you get a little nutrition in that. So he got home, he took one of those and he just stood there and he just down and I'm like, oh, you're gonna be so sick. Because he just chugged it. And you have stitches, you don't want to throw up at all. And he was fine, but I was like, no, stop. He's like, he did fine. He was fine. So no saliva. The mouth was very dry because of the medication. What controls the saliva? We know autonomic nervous system, mostly parasympathetics. And the thought of food, the smell of food, the taste of food, sour stimulus. We know when you get sour in your mouth, you salivate even more. Nausea, you feel like, oh gosh, I'm going to get sick, and you feel that extra saliva coming up. Or you can go the opposite way. It can be inhibited and everything can dry up. Fear does this, fatigue does this. We get too tired and we're all dried out. So that's parasympathetics controlling the salivation. And then we go down into, so nasopharynx, oropharynx, laryngopharynx. So the throat is the passageway from the mouth down to the esophagus. The pharynx is the throat, pharynx. And it's a passageway, strictly just a tube for foods and fluids to go into the esophagus. Anterior, the airway, is the trachea. Posterior is the esophagus. So the esophagus, the laryngopharynx, once we pass the laryngo area, the larynx, then it becomes the esophagus, and it's just a muscular tube leading down into the stomach. So it travels through the chest area, the mediastinum, it pierces through the diaphragm, and then it's going to go into the stomach. So somebody asked about hernia. Have you ever heard of a hiatal hernia? Yeah. That's the stomach coming up into the esophagus. So where the esophagus is piercing the diaphragm, and it'll push up. So if you're pregnant, sometimes that'll happen. If there's a lot of belly weight, sometimes that'll happen. Or in newborns, we'll see this happen, where it'll just poke up in there, and they'll have a hiatal hernia. When I was pregnant, I had this, and it makes you want to throw up constantly. So you just go in, there's a move where you go to the xiphoid process, take a deep breath in, and then you pull it down, and you can just feel it kind of like pick up back in there. So it's constantly like getting in at 45. Don't worry, I don't hernia. It's a disaster. So, but yeah, that's what's happening. It's refluxing up into where the esophagus pierces through the diaphragm. And there's a lot of pressure, so it pushes back. Just like an inguinal hernia does, it pushes up. So then the esophagus comes down, it joins the stomach at the cardiac sphincter. How do we get through the esophagus? There's no digestion or absorption, it's strictly a tube, it's just a passageway, peristalsis. and gravity is what we're doing. All right, questions over esophagus? Into the stomach. So now we're into this big muscular tube. It's a pouch, that's the stomach. It's a storage tank. And we have lots of parts of it that we're gonna label. So here comes the esophagus. That's the cardiac sphincter where the esophagus comes into the stomach. We call that the cardiac sphincter. The cardiac is the top part of the stomach because the heart sits right up here. So this little dip we call the cardiac area. So that's our cardiac sphincter. We have the top of the stomach called the fundus. And then we have the body is the main part of it. So the cardiac region on top. The fundus is the big top part. The whole part of it is the body. And then the big side is called the greater curve. The small side is called the lesser curve. When the stomach is relaxed, this is the inside of it. It has all the plica in there, just folds lying on top of each other. And then it can expand out when we need it to. So it's kind of like a balloon. It just kind of sits in there, real loose and folded. And then when food comes in, all of these coils allow the stomach to stretch out. Overlying that, we have the 3 levels of muscles. We have longitudinal muscles, we have circular muscles, and we have oblique muscles. So we have layers going around it in a circular fashion. We have a layer going longitudinally, and we have on an angle. And they're going to turn, and this layer is going to turn, and that layer is going to turn. So we have this constant washing machine churning kind of action. And that's the mechanical breakdown that happens in the stomach. So those are our 3 layers. And then we have all the curves in there. And then we come to the end, that's called the pyloric region. And where we transition from the stomach to the small intestines is called the pyloric sphincter, or pyloric. So cardiac sphincter up on top, pyloric sphincter down on the bottom. Or sometimes we call it the bowel, pyloric bowel. And then we transition into the small intestines. The first part of that is the duodenum. So that's the stomach. Questions over that? The stomach has motility, so 3 purposes. 1 for storage. We have the 3 layers, so we're going to mix and break things up, mechanical breakdown, and then we're going to empty it out into the small intestines. So we're just breaking things down in the stomach. We're not absorbing, we're just breaking down. And then we have hydrochloric acid that's going to help with the breakdown of everything, and then we're going to pass it on into the water. The gastric mucosal barrier, gastric, is all referring to the stomach. It has tight junctions because we don't want hydrochloric acid getting out. We want it to stay right there in the stomach. So that helps protect it against the enzymes and the hydrochloric acid. It helps protect against the small intestines and the esophagus above. Hydrochloric acid, obviously very strong bacteriocide. It's going to kill everything. Alcohol and aspirin can get across that barrier. So this is why you take aspirin as a blood thinner, but you want to be careful. Aspirin's not coated, it's not enteric. And aspirin can irritate the stomach lining. Certain medications irritate the stomach lining because they can get across that and it can wear holes in the stomach lining. Alcohol, we know, free access to everybody, brain, stomach, wherever it wants to go. We can break that barrier. Enzymes and acids leak out and erode the tissue of the stomach, leading to the peptic ulcer. So if we break that barrier, constant aspirin, constant alcohol can lead to erosion of that, and then we can't withstand hydrochloric acid anymore, and we get that burning peptic ulcer situation.
Is that why it's worse when you have alcohol? We say you'll get ulcers when you put it with carbonated drinks?
Right.
Okay.
Even more irritation. You're irritated, and let's irritate it some more.
Yeah.
Let's just rub some salt into it while we're at it.
But what did you say about aspirin? That you can't take it?
Aspirin gets across the lining as well.
Because
Because it can. It's makeup, it's chemical makeup can get across, just like alcohol. And then it can irritate the lining and wear holes in it.
does that affect the enteric acid too?
Right, so enteric means coated, and it'll have like that colored coating around it, and that's gonna help it not irritate your stomach as much. So like, some people can take Advil, some people can take Aleve, some people can take ibuprofen. They're like, man, that just kills my stomach. That's what it is. It's something that irritates you, which might not hurt the other person, but it bothers you. So it's just irritating that stomach right here. All right, so let's go back to chapter 2, what you consume versus what's absorbed. If we're consuming carbohydrates, remember we're putting carbs in, so we know that's a starch, and the body's going to break that down into glucose. We know we need glucose, that's our chief source of fuel. We need glucose to make ATP. So we're going to break those carbs down, and they come in as the form of starch when we break it down. Here we have our disaccharides, so it's a disassembly line. Remember, lactose is glucose plus lactose, sucrose is glucose and fructose, maltose is glucose plus glucose. So we're just disassembling. We're putting in big things, we're tearing them down into the little things. Complex carbs, simple carbs. We need to tear them down into the little things that we can use. Proteins, remember proteins are long amino acid chains, so we're eating meat. Or nuts, or whatever it is that we're eating for protein, and then we have to break it down. How do we break it down? Into the individual amino acids. So we're breaking down those di and tripeptides. If it's a fatty acids, triglycerides get broken down into their individual fatty acids. So we're taking the macronutrients and breaking down into the micronutrients. And disassembly, big things, breaking down into small things that our body can use. So this is why it's hard to digest a big heavy meat meal, because of proteins, let's say you eat a big steak or maybe a big hamburger, and proteins are long chains, and sometimes afterward you're like, oh, it's so heavy, it's just sitting in my stomach. As you're trying to break down those proteins into the small little amino acids. Or fatty food, you're like, ugh. Afterwards you're like, yeah, it's so good, all those wings and french fries were great. And afterwards you're like, oh. That's your body trying to break this stuff down. And if it doesn't break it down quickly enough, it sits in your stomach and it goes in your gut and it decomposes. And that's what foul-smelling feces and gas is this rotting stuff in your intestines. That's why it smells rotten. That's why it smells bad, because it is. It's sitting in there trying to break down. You're trying to get it moved out of your system. So depending on what's going on. I will take full-body x-rays on people in my practice. And you can see gas in the intestines, and it shows up like bubbles, like gray spots in there. And you're like, oh my gosh, what is that? Do I have a tumor? And you're like, no, that's gas. And you can see backup in their colon. And you're like, what's going on with your digestion? 80% of the population has a problem with digestion. It's $1 billion industry in the US. And they'd be like, oh my gosh, what is that? And it's like, you need to poop. That's what that is. They're like, how often do you go to the bathroom? They're like, oh, I don't know, maybe like once a week. They're like, once a week? Ah! We're like, yeah, gross. I don't want to be around you. But yeah, it's $1 billion industry. And then you have the flip side of that: Crohn's disease, colitis, irritable bowel. Huge, huge industry. And when nutrition-wise, when I'm looking at patients, you always go to the gut first. Are you digesting? If you're not, everything is backing up, and it's going to lead to all kinds of toxins in your system. Whether that be, like acne, things are built up in your system, you can't get rid of them, or you have digestive issues, you can't purify, you can't get rid of those, all those toxins backing up in your system. So I always go to the gut first, and we start addressing that. Everybody gets something that's going to help them with digestion. You get things moving, you feel much better. Because how do you feel when you're constipated? You don't feel good. You're just like, oh, that'd be great if I could go to the bathroom, right? Whether you go every day, every other day, every third day, everybody has their routine. And if you get out of that, you're just like, oh, I don't feel good, right? So yeah, you can see it on x-rays. It shows right up. And then, or if it's just gas, it's clear, it's like gray bubbles. If it's feces, it's solid. You can see it and you're like, holy cow.
Aren't you supposed to, like, if you're eating well or eating right, aren't you supposed to poop after every meal?
At least once a day, sometimes twice a day. Yeah. So if you have enough fiber in your diet, you're eating a balanced diet, you don't have too much fats in it, too much red meats in it, you should be able to go to the bathroom every day. And it should be brown, while we're on the subject. If you have grayish looking stool, that's a fat absorption thing. It shouldn't be gray. If you have a gray stool, the liver and the gallbladder aren't working. And you're not absorbing fat, you're just pushing stuff out. And people are like, yeah. And they don't know how to approach it when they come in. They're like, I'm just having some digestive issues. Okay, well, and they're never going to say my poop is gray. So you have to ask it. You're like, well, how often do you go to the bathroom? Like, okay. Well, what color is it? And I'm like, and you're like, well, it tells us a lot about what's going on. Is it really light? Is it really dark? Is it really soft? Is it really hard? You know, are you having marbles, little pebbles come out? You're constipated. Versus, oh no, I go to the bathroom 5 times a day. You're like, well, that's not normal either. So yeah, you can tell a lot about what's going on there. So digestion, it's a messy subject. All right, stomach. So what's the stomach going to do? It's going to secrete a bunch of stuff. Mucus, we have to keep the lining lubricated. That's throughout the stomach. Pepsinogen, same thing throughout the stomach. Hydrochloric acid is getting secreted in the top of the body. Oh, intrinsic factor, there it is. What does intrinsic factor go with? What vitamin? The stomach secretes intrinsic factors, and then it goes down into the small intestine where absorption happens. So if we're not producing intrinsic factor, in B12, we're not making red blood cells. So that's a key part of the stomach, is secreting intrinsic factor. We have gastrin, the pyloric part of the stomach is secreting that, and histamines in there to keep down inflammation throughout the intestinal linings. So the stomach is secreting all this stuff, and this is why we can tolerate that pH of 2, is because we have pepsinogen and gastrin in there to neutralize that. So we have several different kinds of cells in there that help us withstand that high pH environment. And it has buffers that are in there that helps that area survive that pH environment. All right, and then things go wrong. We have vomiting. So emesis is the fancy word for it. Remember, eupnea was the word for breathing. Emesis is the word for vomiting. So why do we have vomiting? Well, there's a stimulus. We're overstimulated with something. Distension. We've just consumed too much. We've eaten too much or we've drank too much. Bacteria, the stomach is like, oh, we've got a virus, we've got bacteria. Spicy foods, maybe those irritate your stomach. Excessive alcohol, certainly we've witnessed that before. And different medications can make you really, really nauseous. So lots of different reasons that are going to trigger. That's the stimulus. It could be all kinds of stimulus in there. And then what happens is the diaphragm and the abdominal muscles contract and they go in reverse and everything comes up and out. The cardiac sphincter relaxes, the uvula rises, and out comes whatever is in there. And that's why we get into alkalosis, because what is the stomach environment? It's very acidy. If we get rid of too much, we're like, we have the fluid, we're just vomiting and vomiting and vomiting. We're getting rid of too much acid, and we go into a state of alkalosis because we got rid of all of our acid. There's maybe too much in there, but at some point we have to maintain the level, and we just get rid of all of it, so we go into alkalosis. And she exits through. Speaking of emesis. Stop talking. So we know we have that. It's a protective mechanism. The body is trying to get rid of things that are bothering us. All right, questions over stomach. On to small intestine. So now we've left the stomach, we've churned and we've broken everything out chemically and mechanically, and the bolus is what we swallow, and then we get into the stomach and we call that chyme, C-H-Y-M-E, chyme, and we pass that on now into the small intestine. So what we're going to do now is we're going to start absorbing what's in there. So we're going to pass from the stomach to the small intestines through the pyloric sphincter or valve. And then once we're done in the small intestines, we're going to exit that and go to the large through the ileocecal valve. So just like the stomach, we have two valves. The esophagus up on top, cardio sphincter, and pyloric sphincter. Then going into the small intestines, we guard the top with the pyloric sphincter, and we guard the bottom with the ileocecal valve. So two valves there as well. We have the three branches. This is pretty impressive. The duodenum is just that short little turn there. So just the turn from the stomach into the beginning of the small intestines. That's the duodenum or duodenum. And that's about 10 inches in length. Then we go into the top loopy part, the jejunum is about 8 feet. And then the lower loopy part, the ileum, is about 12 feet. So altogether, the small intestines, 12 feet. So all together, we have 20, almost 30 feet of intestines. That's a lot of intestines. Has anybody ever had an abdominal surgery or a C-section? And how does your stomach feel afterwards? Oh, excruciating, right? So we have 30 feet of intestines. They'll go in, if you have your C-section, they make the transverse incision, they move everything out, they cut the uterus, they take the baby out, and they put everything back in, stuff it all in there, sew it back up. Guess what you now have in your intestines?
Yeah.
A whole bunch of
Yeah,
air, a whole bunch of
that's
gas.
awful.
It is excruciating.
Awful.
So when my first one was
I had my
born, he was
appendix out.
C-section, he didn't penetrate, he was early and still breech and all that. And so when they brought him to me to hold, I was like, I don't think I can hold him, I think I'm having a heart attack, because there was so much gas in there. And it was all the way up, like into your neck and everything. It's like, oh my God, it hurts so bad. And they're like, oh, you'll be fine once you poop. We're like, well, when's that gonna happen? And so, yeah, that was not fun. That was unexpected. They didn't tell you to expect that at all. But, yeah, so anytime they open up and that air gets in that cavity, you've got 30 feet of colon to absorb that, plus the outlying stuff. So, yeah, not fun. And that's one of the reasons when you have surgery, they're making sure, well, you can't go home until you can pee this much until you have your first bowel. So they want to make sure you haven't nicked anything or everything is moving properly. So those are two of your things where you can't go home until they know everything is functioning again. So 30 feet of small intestines. Pretty impressive.
So when you have a colostomy, they don't touch the small intestines at all?
Right, usually it's all large intestines. How are we going to move? Same thing, segmentation, peristalsis. Segmentation mixes with enzymes, the chyme. So once we leave the stomach, we're called chyme. The enzymes are mixing with the leftover food stuff. We're contracting. And then we're going to start absorbing. Finally, we're going to start absorbing 12 per minute in the duodenum, 9 per minute in the ileum. And segmentation is moving forwards and backwards, forwards and backwards. So this is how long are the contractions going to be in there? And they're going to last, they're going to be like 12 per minute. We're going to have 12 waves of contraction per minute. So you can feel that, that's what that is. So 12 per minute in the duodenum, and then 9 down in the ileum. So they're moving at different rates is what we're saying here. Moving through peristalsis, when digestion is over, then we go into a fasting state, just meaning, okay, we've digested, we've absorbed everything, and we're done with that. So now